API-ICP training program, virtual training program. We have with us today, we are going to discuss a rheumatological problem. We have with us Dr. Sundaram, the consultant rheumatologist from PSG Institute of Medical Science and Research. Really thank you, Dr. Sundaram, for accepting our invitation and being the faculty for this evening, and welcome you for this evening also. And we have with us Dr. Kaliyarasan, who is going to be the postgraduate who is going to present this case on this rheumatology problem. I request Dr. Sundaram to take over further proceedings of this session. And we're going to discuss only one case. Probably an hour or so will be engage you in this discussion, followed by Dr. Sundaram will give a brief about the approach towards the rheumatological problem. Very, very small tips can be given by him, only for the MD postgraduates. Over to Dr. Sundaram and Kaliyarasan to take over further proceedings of the sessions. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir. Good evening, sir. I'm going to present a case on the topic a rheumatological case. Moving to the case, a 50-year-old female from Salem, farmer by occupation, presented with chief complaints of skin tightening of face, fingers, and feet for the past 3 months, with history of left knee and multiple proximal interphalangeal joint pains with swelling for the past 1 month. The history was given by the patient along with her daughter, and the reliability is good. Moving to the history of presenting illness, patient was apparently normal 3 months back, after which she developed skin thickening of hands, feet, and face, which was insidious in onset, gradually progressing proximally in the limbs to involve until elbows and knees, associated with generalized hyperpigmentation in both upper and lower limbs, with patchy depigmentation, with loss of hair and dryness. No history of any skin nodules. The swelling was also associated with generalized myalgia. Because of the skin thickening of hands, she had difficulty in making a fist and not able to do daily activities like grabbing objects and opening lids. Patient did not have a clear history of Raynaud's, but had pain in the fingertips on exposure to cold water. No history of digital ulcers or finger pitting scars. Skin thickening was not associated with redness, photosensitivity, itching, or burning sensation. History of pain of left knee and multiple proximal interphalangeal joints were present, which were associated with swelling and early morning stiffness of around 30 minutes, which relieved as the day goes on. No other joints were involved. She had difficulty in opening mouth and chewing and swallowing food. No history of ocular dryness. Patient also had a history of heartburn, water brush, and postprandial fullness. No history of abdomen pain, distension, loose stools, constipation, or blood in stools. No history of proximal muscle weakness in the form of difficulty in getting up from the bed, combing hair, or getting up from toilet seat. No history of dyspnea on exertion, cough, sputum, chest pain, palpitations, orthopnea, and PND. No history of reduced urine output or frothy urine. No history of blurring of vision, headache, LOC, or seizures. No history of tingling, numbness, paresthesia, or slippage of chapel. No history of fever, night sweats, weight loss. There was a unintentional weight loss of 5 kgs in the past 6 months with reduced appetite, and there was a history of early satiety in the form of postprandial fullness. No history of any mass in the gross, swelling in the neck, axilla, breast, abdomen, and groin. No history of bleeding or thrombotic events in the past. No history of recurrent miscarriages. No history of patchy thickness of skin, asymmetry of limbs, swell over nape of the neck, or papillary eruptions. No history of any non-traumatic fractures or recurrent infections. No history of exposure to radiation or any anti-cancer drugs. No history of occupational exposure to silica or PVC or any intake of mustard oil. No history of any previous MRI imaging done. Moving to the past medical history, patient was a known case of hypothyroidism diagnosed 1 year back on regular medication. For a brief period in 2024, she had been seen elsewhere for joint pains in her hands, during which she was noticed to have low platelet counts of around 46,000 and was treated with low-dose corticosteroids for around 1 to 2 months, following which she was off treatment for the last 9 months, then presented to the OPD for further management. Not a known case of type 2 diabetes mellitus, systemic hypertension, bronchial asthma. No history of pulmonary tuberculosis, CVA or CAD. For surgical history, nil. Medication history, she's been on levothyroxine, 100 micrograms, daily. Moving to personal history, there were no allergic history, normal sleep, normal bowel and bladder habits. There were no history of any addiction. Menstrual history, attained post-menopause status 1 year back. Family history, nil significant. Sundaram
Dr.
sir?
Kalai, I would
Yes,
like
sir.
you to stop there.
Yes, sir.
So, can you summarize your history?
Sir, the patient is a 50-year-old female who is a known hypothyroid, diagnosed 1 year back, and presented to the OPD with a history of swelling of bilateral limbs with progressive tightening of the skin with arthralgia and small joint pain and swelling, with the history of weight loss and inability to do routine activities due to muscle thickening were there, sir.
Okay.
And who had also had a history of thrombocytopenia in the past and was treated with the low dose corticosteroids. Sir.
Okay, so what do you think is the significance of the thrombocytopenia? Like, what does it
So the
say?
patient would have, sir, since the patient had arthralgia, arthritis, and there could be a underlying autoimmune illness which could have caused thrombocytopenia.
Okay. So, what autoimmune illness can cause skin tightening also? Like, what does, like, can you give me a few differentials from your history?
Sir, the first differentials I would like to keep is systemic sclerosis, sir.
Okay.
And if the patient had an undiagnosed diabetes, it can also have some localized thickening, sir, in the form of scleroderma.
Okay. So,
And
but
if the
where do
patient
you
had,
see scleroderma? Where do you see scleroderma? Generally,
sir, in the nape of the neck, sir, in the
yeah.
nape of the neck, sir.
So when somebody
And
has skin tightening which starts in the fingers, it's usually not
yes, sir.
scleroderma. But see,
Yes,
there
sir.
is some other form of skin tightening which diabetes can cause in the fingers. What is it called?
Sir,
What is the skin tightening which diabetes causes in the fingers called? Okay, which
not
causes
so sure.
difficulty in making a fist.
The,
Okay, it's called diabetic keroarthropathy. So diabetes can
okay, sir.
cause skin tightening in the fingers and the nape of the neck, but this form of diffuse skin tightening is very unlikely. And in a
Okay, sir.
patient who has got a history of thrombocytopenia and arthritis, diabetes is less likely to be the primary cause. Do you have any other
Yes, sir.
differentials?
Sir, if the patient had any infections or fractures, then we can suspect Poem syndrome, sir, or any multiple myeloma which can cause skin thickening, sir.
Okay.
If the patient had any history of uh, thickening in the tongue, we can suspect
Thickening of tongue.
amyloidosis, sir.
Yeah, so see, basically amyloidosis and multiple myeloma you put in the same bracket. Like
Yes, sir.
both are monoclonal gammopathies. So monoclonal gammopathies, what is the difference between the skin tightening in monoclonal gammopathies versus like say systemic sclerosis? Is there any difference?
Sir, in multiple myeloma, it can have a patchy involvement, sir, and
Yeah,
it can go from distal to proximal, sir. But in case of scleroderma, it's mostly a symmetrical involvement.
What do you mean by distal to proximal skin tightening?
Sir, initially they start to notice in the hands, sir, then followed by in the forearm and
See,
arm, sir.
what you typically call as scleromyxedema is not something which starts in the hands. It can have
Okay, sir.
puffy fingers, but it is the scleromyxedema is actually something which, like you mentioned in your presentation, that it comes
Nice,
with
sir.
this
It can
waxy
have the
papules.
papillar
Yeah,
eruptions, sir.
so it's
Tiny
basically
papule.
a papular eruption which associated with a skin tightening. So this sort of a skin tightening which starts in the fingers then progresses to the hands, forearms, and I think this is not generally what you find in what is technically called scleromyxedema.
Yes, sir.
Okay. Uh, what else?
And sir, we can even suspect if the patient had any unilateral wasting, we can suspect linear
No, but
linear
see,
scleroderma,
in
sir.
such a case, you never suspect linear scleroderma because the patient has skin tightening in all four limbs.
Yes, sir. In this
Okay.
case, it's symmetrical and involves all the
Yeah.
limbs,
Okay.
sir. So
So
it's not.
you can't call this a localized scleroderma. Okay. So
Yes, sir.
then so that is out of question. You cannot think of those conditions. What
Yes, sir.
else? Is there
Sir,
anything?
if the patient had any mustard oil exposure, then we can suspect epidemic dropsy, where the patient can have symmetrical.
Yeah. Yeah. So see, according to me, this whole
Yes,
epidemic dropsy, arginine oil mixed with mustard oil, contaminated mustard oil thing, it was actually for a brief while very common in North India, and
okay, sir.
it is pretty prevalent in very rural places of North India where there is contamination of oil. I don't think it is common in Tamil Nadu. At least I have not come across it, but
Yes, sir.
it's quite common in the hinterlands of. And see, those conditions are extremely painful conditions.
Okay, sir.
Such patients, see, it is because of an edema that happens in their body that you feel like it is a skin tightening,
Yes,
and
sir.
those patients will have a cardiac failure like condition, so they'll have significant breathing difficulty and things like that. So that is something you see in epidemic dropsy, but it's a good differential that you need to consider, which is important in the Indian context.
Yes, sir. Then, if the patient would have taken any anorectics, then we can suspect any eosinophilic fasciitis, sir.
Okay. So eosinophilic fascia, do you think it will be there in all four limbs?
No, sir. It will be asymmetrical, and there will be again papillary
You don't need a papillary
nodular
rash. It
eruption,
can
sir.
be, so usually it will be regional. It will
Yes,
not
sir.
be, it will not be symmetric like you said, and it won't be
Yes, sir.
like, starting distally and progressing, from one region to the other. So most of
Yes,
the
sir.
time you will find eosinophilic fasciitis only in one arm or in one forearm.
Yes, sir.
Hmm. So can you once again summarize the your positive findings for the sake of the audience?
Sir, the
Positive
patient,
history.
sir, the patient has history of symmetrical progressive skin thickening with
Mm-hmm.
arthralgia and arthritis, sir, of
Mm-hmm.
especially small joints and knees, sir.
Okay. Mm.
With previous history of thrombocytopenia and hypothyroidism. For which she was briefly on steroids, and currently she's on levothyroxine 100 micrograms.
Okay. So, what is your primary differential here?
So at present, my primary differential would be systemic sclerosis. In that, to be specific, it can be diffuse systemic sclerosis.
Okay. Do you have any other differential?
Sir,
Is there any
no.
other autoimmune connective tissue disease that can come with skin tightening within, like, such a diffuse skin tightening within a period of 3 months?
Sir, we can suspect MCTD. We can
Yeah,
even
you
suspect any
expand MCTD
paraneoplasm.
when
Hello, sir.
you expand MCTD, don't.
Mixed connective tissue disorder,
Okay.
or if there is any paraneoplastic syndromes, it can also have some symmetrical thickening, sir, in case of any
Like,
breast carcinoma.
what are the factors that make you suspect paraneoplastic in this case?
So the patient had a weight loss, sir, 5 kgs, unintentional weight loss.
Okay, the patient is not able to eat. What else? What is the most important factor in this case that makes you suspect paraneoplastic?
Sir, it is progressive. Within 3 months, the patient had a worsening course.
Yeah, so it is the speed of the skin tightening. So when somebody has within a period of 3 months, say, such a diffuse skin tightening where they have involvement until the elbows and in the face, you need to consider paraneoplastic as one of the differentials.
Yes, sir.
Okay. Um, okay. Why did you, like? What did you specifically ask for in the family history? You have written this, nothing so significant. Like, what were the things you asked for?
Sir, any family history of any hypothyroidism, vitiligo, or any history of Raynaud's syndrome, then lupus, then the patient as an increased risk for developing systemic sclerosis.
Okay, you mean
That's
to say
the specific.
you asked for history of autoimmune disease with a
Yes,
symmetric,
sir.
similar genetic risk factors?
Yes, sir. Those who are susceptible to PTP and mutations.
Okay,
Polymorphism.
suppose this patient has a 20-year-old daughter who has a history of Raynaud's phenomenon. This patient does not have a Raynaud's phenomenon. Does it make her at increased risk of Raynaud's phenomenon? I mean, at increased risk of autoimmune disease? Like suppose
Yes,
she has a daughter who has Raynaud's phenomenon.
Yes, sir.
Does it make her at increased risk of autoimmune disease?
Sir, for her daughter, it can be Raynaud's disease, sir. We can't be sure, sir. But if there is a family history, then there is a strong suspicion that we can suspect autoimmune disease in her also.
See, so basically, you want to how do you differentiate between primary and secondary Raynaud's?
Sir, in primary Raynaud's, it will be around. It will be in the younger age, sir, and when the ANA profile will be negative, sir, and the capillary nail fold will be normal, sir.
Okay. What else? See, before you go into all these investigations and things like that,
yes, sir.
What else will make you help you differentiate between a primary and a secondary Raynaud's?
Sir, there won't be any digital ulcers or gangrene, sir.
Okay.
Or any pitting ulcers.
Okay, number one, very good.
And it will be mostly self.
You mean to say the secondary changes won't be there? What else?
There won't be any associated.
Can somebody with primary Raynaud's have skin tightening?
Yes, sir. In primary, there won't be any other associated issues, sir, like skin tightening or.
Can somebody with primary Raynaud's have oral dryness?
No, sir.
Yeah. So basically, when somebody has a pretty good systemic illness, then it is very unlikely that it is primary Raynaud's.
Yes, sir. Yes,
so, okay. Yeah, you carry on.
Yes, sir.
So, what are the things you are expecting? Suppose this patient has got systemic sclerosis or mixed connective tissue disease.
Yes, sir.
What are the before you go into the examination? What are the important systems you want to examine this patient?
Sir,
and that her disease is limited to skin and joints.
Yes, sir. In systemic sclerosis, there are two types, sir. One is diffuse and another one is limited, sir. In limited, the main thing we have to focus is CREST syndrome, sir. That is calcinosis, Raynaud's phenomenon, and then esophageal dysmotility issues, telangiectasia. And the patient will have a higher risk for pulmonary artery hypertension, sir. Okay. In limited systemic sclerosis. And the patient, and we have to look for any other associated myalgias or any other muscle weakness we have to see, sir. Okay. Then in esophageal,
this patient does not have limited; she has diffuse. Now,
so in diffuse, we have to look for any signs for ILD, tendon friction rubs. Then any other. Like renal any history of any suggestion of any renal crisis you have to see, sir, and contractures.
Okay.
And if there is any pleural rub, we have to suspect pericarditis, and patchy myocardial fibrosis also we can suspect it.
Okay. So do you think diffuse cutaneous systemic sclerosis does not have pulmonary hypertension?
Sir, on a long-standing ILD, they can go for chronic hypoxia. It can go to pulmonary hypertension, sir. But with limited, the pulmonary hypertension is the risk of pulmonary hypertension is very high, sir, compared to.
Yeah. Okay, it's actually not like that. So there are many disease phenotypes in which you have combined ILD as well as pulmonary hypertension. Like
Okay, sir.
if you would have read phenotypes associated with certain antibodies, they are at
Yes,
increased
sir.
risk of ILD as well as pulmonary hypertension. Okay.
Okay, sir. Yes, sir.
We'll go into that in the subsequent discussion. So you just
Okay, sir.
because somebody has interstitial lung disease or somebody has a diffuse cutaneous systemic skin tightening does not mean that they cannot have pulmonary hypertension at baseline. They can very well have pulmonary hypertension at baseline,
Okay, sir.
even before they've had like long-standing lung illness. So
Okay, sir.
cannot make such assumptions here.
Okay, sir.
Okay, so you carry on with the examination.
Yes, sir. Moving to examination, general examination. Patient was conscious, oriented, comfortable at rest. Patient had mild pallor, no icterus, cyanosis, clubbing, pedal edema or lymphadenopathy. JVP was not elevated. Vitals, blood pressure 110 per 70 mmHg in bilateral upper limbs. Pulse rate 74 beats per minute, regular in rhythm, normal volume, no specific character, no radial or radiofemoral delay. Vessel wall not thickened. Saturation 97% in room air. Respiratory rate 18 per minute. Moving
Like
to head to
suppose,
foot examination.
I can stop there. Suppose this patient has a
Yes, sir.
BP of 140 on 100.
Yes, sir.
Suppose this patient has a BP of 140 on 100.
Yes, sir.
What will you suspect?
Sir, we have to suspect if the patient goes for any renal crisis, sir, scleroderma crisis. And we have to start on ACE inhibitor.
Okay. So suppose a patient has a BP of 140 and 100. What is
Yes,
the first thing you should do? Okay, you said you'll start her on ACE inhibitors. What else? What is the next thing?
We have to look for urine proteinuria or any hematuria, sir.
No. Before that?
We have to look for either thrombocytopenia if there is anything.
Okay.
Thrombotic
So
microangiopathy.
this patient had a history of thrombocytopenia. What else?
Yes, sir.
But more important.
Thrombosis.
No, thrombosis. You won't have any large vessel thrombosis in such case. Suppose when you have somebody suspected to have scleroderma renal crisis.
Yes, sir.
Yeah. What is the first thing you'll do?
Fundus examination.
Fundus, yeah. Okay, fundus.
Yes, then,
okay. What will you find?
Sir, papilledema.
Yeah, possibly papilledema. You'll find features of malignant hypertension.
Okay, sir. Yes, sir.
Yeah, so this malignant hypertension is because of some renal cause. So
Yes,
when
sir.
you have, like suppose somebody has come to you with scleroderma renal crisis,
yes,
and you biopsy their kidney, like somebody
yes,
has come to you acutely, what will be the finding there?
So there'll be fibrin deposition in the vessels.
See, there's something called thrombotic microangiopathy.
Yes, sir.
It's called TMA. So what will you find in TMA?
Vascular thrombosis, sir.
No.
I'm not so sure.
So the first thing you need to look for, suppose you have somebody of systemic sclerosis, especially with such a significant skin tightening, is you need to look for schistocytes. Okay, so when somebody has scleroderma renal crisis, one of the first things that happens is they have a rise in LDH, they have high BP, and they'll have schistocytes in blood. And obviously, you'll also look for thrombocytopenia, anemia, and all those things. One of the earliest findings you get is schistocytes in your blood.
Yes, sir.
Obviously, if there is a rise in creatinine, you need to look for creatinine. Suppose somebody has a baseline creatinine of 0.7 and they come to you with a creatinine of 1.4,
yes,
then also you need to think of scleroderma renal crisis. Any rise in BP,
yes,
even a borderline BP like 140-90 is a big risk factor, especially if they previously had a BP of 140-70. So, especially somebody with such a rapid onset skin tightening, you need to be very, very, very careful, especially with the history of taking steroids. You need to be careful of scleroderma renal crisis.
Yes, sir.
Yeah.
Yes, sir.
Yeah. Yeah, carry on.
Yes, sir. Moving to head to foot examination. Faces. Musk-off face is present, that is pinched nose, periorbital puckering, thinning of lips, microstomia, with interincisor distance of less than two fingers. Simmers were 11 mm. There was reduced oral salivary pool with multiple caries. Skin thick tone in the next slide, and No finger tip pitting scars or digital ulcers or amputation of fingers noted. Periangual hypopigmentation was there. Nail dystrophy was present in the left fourth finger, which was post-traumatic. No calcinosis or telangiectasias. No rashes or plaques. Moving to the skin thickening, which is modified Ransom score, skin score. The patient had a score of 26.
Dr. Kalai, it's modified Rodnan skin score.
Rodnan.
Rodnan skin score.
Modified Rodnan skin score. And the patient had a score of 26. That is 3 in the fingers and hands, 2 in the forearms, face and feet, and 1 in chest, abdomen, and legs.
Okay. So what does this score suggest? Like, does it have any prognostic significance?
Sir, the maximum score is 51. Since this patient had a score of 26, it also it shows that the patient has worsening course. Like it also helps us in prognosticating and treatment values. We can assess treatment response.
In what way?
Sir, post follow-up, we can assess the score. We can recheck the score.
Yeah, that's fine. But in terms of prognosis, skin tightening is not going to kill the patient. What is it going to tell you in terms of prognosis?
Survival.
Yeah.
The patient has a worse score, then the probability of his 5-year survival will be less.
Because of what?
Because of other systemic involvement.
Yeah, so that is the most important thing. When somebody has a very bad skin score, they are at increased risk of internal organ involvement, and that those internal organ involvement includes lung, heart, kidney, pulmonary vasculature in the form of pulmonary hypertension. So it puts them at increased risk of everything, internal organ involvement. So, and what they say is that if you have like such a rapid progression of change, then it becomes an indication for what?
Sir, it becomes an indication for biologicals, rituximab.
Immunosuppression, that's all. It's not an indication for biologicals, it is an indication for immunosuppression.
Okay, sir. Yes, sir.
Okay, so just because you touched upon the immunosuppression part, what are the drugs you can possibly give in somebody with rapidly progressive skin tightening? What are the drugs which have shown some benefit in rapidly progressive skin tightening?
Sir, we can try rituximab, sir. Then we can try TNF alpha inhibitor, sir.
No.
Not so sure, sir.
Okay. Carry on. Yeah.
Yes.
We'll come to this at the end of the discussion.
Yes, sir. Musculoskeletal examination. The patient had no obvious contractures. The patient had difficulty of making a fist because of sclerodactyly. In both the hands, second to fifth proximal interphalangeal joints are tender. Left knee was swollen and tender. Other joints were normal. MCP, MTP squeeze were negative. Muscle examination. Power was grossly normal, 4+/5 in all the groups, including neck flexors. The patient was able to roll over in the bed and was able to get up from supine position with the support of both hands. Single breath count more than 20. As you can see, this patient has a Z deformity, and there is a puffy fingers with left fourth finger has nail dystrophy and hyperpigmentation. And the patient also has periangual hypopigmentation. Moving to systemic examination, serious examination, S1, S2 is normal, no loud P2, no murmur or pericardial rub. Respiratory system examination, normal vesicular breath sounds, bilateral basal fine velcro crusts noted with occasional inspiratory squeaks present. Per abdomen, soft, non-tender, no hepatosplenomegaly, no free fluid, normal bowel sounds. Cranial, central nervous system examination, cranial nerves were normal, no focal, motor or sensory neurological deficits. Moving to his investigations, CBC showed HB of 11.9, MCV 89, and the WBC was 5,000 with neutrophils 68%, lymphocytes 28%. Platelets were around 47,000. ESR and CRP was normal, there was slightly increased. Uric acid, LFT, RFT, urine complete, urine PCR, and CPK were within normal limits. ANA-IF showed homogeneous 3+, 1:1000 dilution. ANA profile was strongly positive for SCL70, and viral serology was non-reactive. Chest X-ray showed bilateral increased reticular opacities in bilateral lower zones. Her limited FT showed TSH of 7 and FT4 of 1.10. This was her X-ray and CT chest, sir.
Okay.
So you can see, yes, sir. As you can see in the chest X-ray, she had bilateral basal increased reticular opacity, sir. And in the CT, there were mild honeycombing with septal thickening, sir. But there was no gross cystic changes or architectural deformities, sir. Suggestive of probably NSIP, sir. NSIP.
Okay. So, see, from
Yes,
your history, there was nothing
Yes,
to
sir.
suggest interstitial lung disease. But
Yes, sir.
from
Yes,
your examination, there was some doubt that there could be interstitial lung disease, and
Yes,
your CT suggests that there is some interstitial lung disease. Do you think this
Yes, sir.
interstitial lung disease is significant enough to start treating the patient?
Sir, since the patient had worsening skin thickening and now we have evidence for ILD, then the patient might benefit from intensive treatment.
Like, what I
to
mean to
prevent
ask is, will you wait
progression.
for some time before starting treatment for ILD, or will you treat now?
Sir, I will go ahead with treatment, sir. Since the
For
patient had a
ILD.
very short course. Yes, sir.
So, like, suppose you have this patient, before you start
sir.
treatment for ILD, what are the other things you'll do?
Sir, we can try MMF, sir.
No.
Hello, sir.
See, before you start any treatment,
Sir.
MMF is a treatment for interstitial lung disease. I'm asking,
Yes,
before
sir.
you start
Yes,
treatment, what are the things you'll do?
Sir, we can assess functional status at 6 months.
Okay.
Whether she's
Yes,
able
it's a
to,
functional status.
sir, whether this ILD is actually causing her any functional issues.
Are there any objective tests to assess for functional status? You have looked at her anatomically.
Yes, sir.
How will you assess functional
status?
Yeah.
6 minutes walk test we can do, sir.
Sorry? Yeah, okay.
6 minutes walk test.
What does it tell you?
See, sir. It tells her pulmonary reserves, sir.
Okay.
How much can
Okay.
tolerate.
Suppose 6 minute walk distance is 200 meters. Then what?
Yes, sir.
What else
then,
will you do as part of functional assessment?
We can I'm not so sure, sir.
Okay. So you do pulmonary function test, right?
Yes, sir. Yes, sir.
You do pulmonary function test, you look at our FEC, you look at our FEV1, you look at the peak expiratory flow rate, BF50, MEF50, all those things. You also look for DLCO. Suppose this patient, in your investigation slide, just go back.
Yes, sir.
Suppose this patient has a raised uric acid. What does it tell you? Like you mentioned uric acid, right? What does it tell you?
Yes, sir. Yes, sir. Sir, since I'm not so sure, sir.
Okay. So, see, raised uric acid in a patient with systemic sclerosis,
yes, sir.
It suggests that there is a risk of pulmonary hypertension. So it is one of the subtle signs of pulmonary hypertension, because uric acid is raised when there is a right heart strain. So that is one of the signs.
Okay, sir.
Obviously, when you have a decreased renal function, you'll have increased uric acid. So increased uric acid can be a clue for pulmonary hypertension.
Okay, sir.
Okay, suppose you got a patient. This patient has a FVC of 90% and
Yes, sir.
and DLC of 60%. What does it suggest?
Sir,
Like suppose a near normal FVC and a
yes,
low
sir.
DLC, what does it suggest?
Then the patient might have pulmonary artery hypertension, sir.
Yeah. So that also suggests a pulmonary artery hypertension.
Yes, sir.
So what other assessment will you do when somebody you think that the patient has got ILD? You do a PFT with DLCO. You do what is this? You do a 6-minute walk distance.
We'll
What
do
else?
echo.
You do an echo also.
Yes,
So
sir.
because it
Any
has
RA
functional
as well.
significance, because you might be this reduced 6-minute walk distance could be because of ILD as well as PAH. Okay,
Okay,
so
sir.
it does not give you
Okay,
an
sir.
accurate assessment of what is contributing to what. So you do a baseline cardiac examination also, because
Okay, sir.
for all you know, this patient could have some myocardial disease, left heart
Sir.
disease, right?
Yes, sir.
This patient could have like say something called PVOD, pulmonary veno occlusive disease, which can cause pulmonary hypertension. This patient could have
Okay, sir.
a valvular disease, which can be associated with autoimmune disease, chronic MRs and things like that. So
Okay,
even
sir.
though you have not mentioned it, your cardiac examination is normal, you need to do an echo also before you start any
Okay, sir.
treatment for ILD, right?
Okay, sir. Okay,
Okay.
sir.
Like why
Yes,
else?
sir.
Like suppose you have done all these things and you find that this patient has got a functional decline,
Yes,
but
sir.
still the patient does not have symptoms. Why do you need to treat the patient for ILD?
Sir, the patient has a risk of progression, sir. Even though at
Yeah.
present the
So
patient might be
what in this patient suggests that the patient has a risk of progression?
skin worsening of skin thickening,
Yeah,
sir.
it's the
Within
speed
3
of the
months
skin
of
tightening. It's the
yes, sir.
rapidity of the skin tightening which suggests that the patient could have a rapid internal organ involvement as well. So
Yes, sir.
you need to start treating the patient early.
Okay, sir.
What else suggests that you need to start treating the patient early? It is there in your screen.
The thrombocytopenia, 47. And the SCL70 was strongly
Yeah,
positive,
so
sir.
SCL70 is
Strongly positive.
associated with a increased risk of progressive ILD. So you start treating the
ILD
patient.
progression.
Yeah,
Yes, sir.
fine.
Yes, sir.
I mean,
Sir.
let me move on to the next slide. Is there anything else you want to show?
Yes, sir.
Yeah.
Sir, this is the score, sir, for the Euler score for systemic sclerosis, sir. The patient has a score of 18, sir. In this,
Do you need to count till 18 in this case?
Sir?
Do you need to count till 18 in this case?
No, sir. When the patient had bilateral finger involvement, that itself it denotes that the patient, like if the score is around 9, then the probability of systemic
It's not
sclerosis
around
is
9. If you have that, it says that it is a
that is
sufficient
the
criteria.
sufficient criteria, sir.
Okay.
Yes, sir.
Okay, so do you like if you get a case of like say you are suspecting systemic sclerosis, do you use this criteria to diagnose them?
Sir. So this includes both phenotypes, systemic and the diffuse and limited, sir.
Okay.
But mainly this when we note that the patient has thickening in the bilateral fingers, then that itself is shows that the patient has more probability of diffuse scleroderma.
See, the most important things you need to see in this case is the first item. The skin tightening of the fingers of both hands. It is the first item. And whatever is written in the bottom. You rule out the other mimics. That's all.
Yes, sir.
Okay.
Okay, sir. Yes, sir.
That's the only important thing. See,
Yes, sir. Yes, sir.
See, when you are an MD resident, it's very important to
Yes,
read
sir.
these criteria because it gives you an idea about what looks like systemic sclerosis and what can
Okay, sir.
mimic systemic sclerosis.
Yes, sir.
Okay,
Yes,
it
sir.
gives you an idea of what is a typical case. But
Okay, sir.
in individual cases, you should not like go and keep applying this criteria for every case because see,
Okay, sir.
all criteria, most of the criteria in rheumatology are all classification criteria where there are cases in which your case might not fit into this criteria. Like they might have skin
Okay,
tightening
sir.
of the fingers only, just puffy fingers with a score of 2. They might not have any fingertip lesions. They could have abnormal nail fold capillaroscopy and a
Okay,
positive
sir.
scleroderma antibody.
Okay,
What
sir.
score does it give them? Like puffy fingers plus nail fold capillaroscopy plus SEL70. Even that can be labeled as having
Yes,
systemic
sir.
sclerosis, but
Yes, sir.
it won't fulfill the criteria. So it is not necessary that you need to
Okay, sir.
100% fulfill this criteria to put a patient as having systemic sclerosis. Especially
Okay,
suppose
sir.
somebody has an very early systemic sclerosis, and you want to like pick the patient up early. Sometimes
Yes,
in
sir.
those cases the patient won't fulfill the criteria. The use of
Okay,
this
sir.
criteria is
Is to
when you
differentiate from. Yes, sir.
is when you form any cohorts. Like suppose you want to have any cohort, like you're at PSG hospital, you want to form a systemic sclerosis cohort.
Okay,
You
sir.
need to ensure that there is a uniformity between the cases.
Okay,
So
sir.
that is where you need to say that, okay, all the patients in this cohort fulfill this criteria. That is the ACR regular classification criteria for systemic sclerosis. That is why you need this criteria, not for diagnosing
Okay, sir.
individual cases. You need to understand
Okay,
that.
sir.
It gives you a
Okay, sir.
very good idea about individual, like when to diagnose, when to not. Like this
Okay,
gives you
sir.
an idea that when you have a systemic sclerosis, you need to look for ILD and pulmonary hypertension. So it gives you a
Okay,
very
sir.
good idea about
Okay, sir.
those things, but it does not give you a lot of
Okay,
idea
sir.
about a lot of other things. It does not tell you about any cardiac disease, does not tell you about any renal disease, does not tell you about
Yes,
anything
sir.
about GI disease, esophageal
Yes,
dysfunction.
sir. Yes,
So
sir.
if you take patients with limited cutaneous systemic sclerosis, most of the time they won't fit the criteria. Like
Okay,
say
sir.
they have puffy fingers and they have anticentromere, okay,
Okay, sir.
and they have
Okay, sir.
arthritis, okay.
Okay,
Do you
sir.
think that patient will fulfill criteria for limited cutaneous systemic sclerosis?
Yes, sir. Patient will fulfill, but this classification, that score will be less.
They won't fulfill the criteria. See, one of the even since you said that this limited cutaneous systemic sclerosis is CREST syndrome, it is much
Yes,
more
sir.
than that. Okay. So limited
Yes, sir.
cutaneous systemic sclerosis means it is limited cutaneous skin tightening. It can have
Yes, sir.
arthritis. One of the most important clinical findings in anticentromere associated disease is arthritis. It can
Okay,
also
sir.
have what else? What else does antibody cause?
Sir, it can cause digital gangrene, sir. Those
Yeah,
patients will
okay.
have.
Like it all comes under whatever you said as CREST. What is not in CREST, which can happen in limited cutaneous systemic sclerosis?
Sir, I'm not
You
so sure.
said pulmonary hypertension, right?
Yes, sir. Yes, sir.
Pulmonary hypertension
It
is
can
one
cause, yes,
important
sir.
thing.
Limited as higher.
Yeah.
Sir,
No, no, no,
pulmonary
no.
hypertension.
Both have higher.
Okay,
Limited
sir.
can cause pulmonary hypertension without ILD.
Okay, sir.
Okay.
Okay, sir.
Most of the time,
Okay, sir.
diffuse cutaneous will be. So when you have usually what happens is your severity of skin tightening mirrors whatever is happening in your lungs. Okay.
Okay, sir.
Okay. So when you have limited cutaneous, usually the lung can be spared, but it is not 100% the case. So
Okay,
if
sir.
you take SCL70 is the thing which is associated with the increased risk of ILD. And
Okay,
if
sir.
you take diffuse cutaneous skin tightening, 40%
Yes, sir.
of patients with diffuse cutaneous skin tightening will have 40 to 50% will have SCL70, and they have
Okay, sir.
increased risk of ILD. On
Okay, sir.
the other hand, 10% of all patients with limited cutaneous skin tightening can also have SCL70.
Okay.
So limited cutaneous skin tightening does not rule out the possibility of having ILD.
Okay, sir.
What decides the risk of having ILD is the
Antibody.
antibody. So antibody is
Okay, sir.
very important. And
Okay, sir.
like to reiterate, a lot of patients with limited cutaneous skin tightening will not fulfill this criteria. Okay.
Okay, sir.
But that does
Okay,
not
sir.
mean you cannot diagnose them as having limited cutaneous systemic sclerosis.
Okay, sir.
Another thing which can occur with anticentromere is Sjogren syndrome. So 5%
Okay, sir.
of patients with anticentromere can have Sjogren syndrome. So
Okay,
that's
sir.
another thing you need to consider. And what else?
Okay,
Anticentromere
sir.
can also cause some muscle disease. So you need to first understand that limited cutaneous skin tightening or limited cutaneous systemic sclerosis is not just that acronym called CREST. It is a lot more.
Okay, sir.
Okay.
Okay, sir.
Mm.
Yes, sir.
And you don't have to count this. Nobody is
Yes,
worried
sir.
about what score they achieve in this. So you won't find any
Okay,
cohort
sir.
where they'll calculate the total score from this criteria. That is immaterial. This patient has had a diagnosis. You have diagnosed the patient as having systemic sclerosis, and you can put the patient into any cohort of systemic sclerosis because the patient fulfills the classification criteria.
Okay,
Right?
sir.
Yeah.
Yes, sir. Yes. The diagnosis is systemic sclerosis, diffuse systemic sclerosis with organ involvement of lung, that is fibrotic NSIP with arthralgia.
Okay. You didn't do echo in this patient.
Sir, we
Yeah.
didn't.
So ideally, you should have mentioned the PFT and echo. Okay.
Yes, sir. Yes, sir.
Okay. So let me ask some important clinical questions in such a case. Like suppose you got a patient who has diffuse cutaneous skin tightening and you expect them to
Okay,
have
sir.
ILD. Suppose this patient has no lung involvement. What does it signify?
Sir, it could have been favorable prognosis. And
No,
I'm not so
no,
sure.
definitely not
I'm
favorable
not so sure.
prognosis. This rapidly progressive skin tightening is always a sort of a bad thing only. Favorable
Okay, sir.
prognosis means you won't treat the patient, right? You'll wait. What do you mean by favorable prognosis? We are not in a hurry to treat the
Yes,
patient.
sir. Yes, sir.
Mhm.
Yes, sir.
Okay. So this, when you have such a bad skin tightening with lack of ILD, it makes them at increased risk of having anti-RNA polymerase 3 antibodies, which
Okay, sir.
increases the risk of malignancy. So lack of ILD is also a bad thing when you have bad skin disease.
Okay, sir.
Okay.
Okay, sir.
So what else will you find? Suppose you have a patient with rapidly progressive skin tightening without ILD. What are the other things which suggest an increased risk of malignancy?
Sir, it was not clear, sir. Can you come
Okay,
again?
so so suppose you have a patient with rapidly progressive skin tightening
Okay, sir.
without any ILD.
Okay, sir.
What are the other clinical factors which suggest that they could be at increased risk of malignancy?
Sir, if the patient has worsening GERD symptoms,
So GERD, everybody has GERD. All patients with systemic sclerosis,
sir,
you take
the
limited diffuse, everybody will have.
dysmotility if they had then
No, 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 no. Okay. So you mean to say GERD is because of
any
esophageal cancer?
illicit habit,
Sorry?
smoking. Okay. If the patient had any exposure to smoking,
Okay.
already
Okay,
a
that's an
scarred lung,
associated
then
factor. Like clinically, what are the things like skin tightening is there, ILD is not there. What are the other things which suggest that they could have increased risk of malignancy? Okay, there are only three things. Okay.
okay, sir.
Number one is joint contractures.
Okay, sir.
Okay, tendon friction rubs,
Friction rubs. Okay, sir.
right? And
Okay.
pericardial
Rub.
disease, pericardial rub or pericardial effusion, things like that.
Okay, sir. Okay,
And
sir.
if they have had a SRC in the past.
Okay, sir.
Okay, so these are the things which are usually associated with this antibody called RNA polymerase 3, and
Okay, sir.
that increases the risk of malignancy like anything.
Okay, sir.
Okay, so
Okay, sir.
uh, especially malignancy of the esophagus, somewhere in the GI or lung. Sometimes it can be
Okay,
in the
sir.
breast also. So
Okay, sir.
when you have this RNA polymerase 3 antibody, these are the two things you need to be really scared of. One is malignancy, number two is SRC,
Okay, sir.
scleroderma crisis.
Okay, sir.
Okay.
Yes, sir.
Is there anything in the history of this patient which puts her at increased risk of scleroderma renal crisis?
So steroid usage, sir. Initially,
Yeah.
she was on steroids, sir.
Okay. What steroid is it? How much steroid? Is there any like
Sir,
value?
usually high steroids, the patient as the dose of steroids increases, the patient's risk for renal crisis increases, sir.
Yeah. So any dose, what has been said, there are various studies about this. So any dose above 7.5 or more, or some studies say 10 milligram per day prednisolone or more, it puts the
Okay,
patient
sir.
at increased risk of scleroderma renal crisis. In fact, the
Okay,
first
sir.
patient of RNA polymerase 3 I saw who had like a
Okay, sir.
very similar history, she like
Okay,
we
sir.
didn't know that she had RNA polymerase 3. She had very bad arthritis, very bad pains, and that was a time when we did not
Okay, sir.
have any testing for RNA polymerase 3 also. Okay. So
Okay, sir.
we
Okay, sir.
actually gave the patient steroids, and lo and behold, in 2 weeks she came with renal crisis, and then we were forced to get her RNA polymerase 3 from an
Okay,
outside
sir.
lab, and she was obviously positive. So
Okay,
in
sir.
this case, it is very important to to decide the prognosis.
Okay, sir.
Yeah, in terms of antibodies, what are the possible antibodies do you think this patient could have?
Sir, this patient, since the patient had dry dental caries with the Shimmer's 11, the patient can have anti-Rho, sir.
Okay. So do
Then,
you think
since
any patient with systemic sclerosis, what is the probability that they could have secondary Sjogren's?
uh,
So do you think
it
the patient
can,
has got primary Sjogren's or secondary Sjogren's?
sir, it could be secondary job, like associated with the scleroderma, sir, not
Okay. Okay. So you think the
individual
patient has got
disease.
secondary Sjogren's? Does secondary Sjogren's need the presence of Rho antibody?
I'm not so sure, sir.
No, it does not need. So
Okay, sir.
see, you find secondary Sjogren's in almost 20% of cases of systemic sclerosis.
Okay, sir.
Okay. So, and most of the patients, you will be surprised to find most of the patients won't have any Rho 60 antibody. So you don't need Rho
Okay, sir.
antibodies to diagnose them as having secondary Sjogren's.
Okay, sir.
Okay. Right. So what else?
Okay, sir.
What are the antibodies? Like, see, this patient who
Yes,
has
sir.
diffuse cutaneous skin tightening plus
Yes,
lung
sir.
involvement, what are the antibodies you think they could possibly have?
Sir, they can have THO.
No, THT0 mostly has limited skin tightening only.
Okay, sir.
Hmm.
The patient can have PML-SCL, sir, since myalgia was there.
Yeah.
But
So
CPK
PMSCL
was
is one of the things which can cause diffuse cutaneous skin tightening and ILD also. What else?
okay, sir. Sir, there can be anti-Q, sir, but if they will have SLE, sir, usually.
No,
SLE
it is
with,
not necessary that they have SLE. They can have
okay,
just a
sir.
systemic sclerosis-like phenotype. So Q is
Okay,
also
sir.
possible, but Q
Okay, sir.
generally does not cause such a bad skin tightening.
Okay, sir.
Okay, it can cause
Okay,
ILD, so it can cause myositis, but it does not cause. So Q basically has two phenotypes. One is a lupus-like phenotype, and the other one is a CTD-like phenotype where they have myositis and ILD. Skin
Okay,
tightening
sir.
won't be so bad. What else?
Okay, sir.
You had it in your initial differentials. What other antibody can have diffuse cutaneous skin tightening and lung involvement?
Sir, U3-RNP, sir. Fibrillin.
U3-RNP, yeah, possible. Okay. U3-RNP is very rare.
Sir,
U3-RNP is
RN,
fibrillin.
yes, sir. Then that's for RNP3, then SCL70.
Hmm.
I'm not so
What
sure,
is
sir.
common in India? U1-RNP. U1-RNP
No,
is
sir.
very common.
U1-RNP, sir. Okay.
U1-RNP is very common. U3-RNP, THT0, they are all very rare antibodies.
Okay, sir.
You'll be happy to see one or two cases in your lifetime. But U1-RNP is very common.
Okay, sir.
And U1-RNP can also cause diffuse cutaneous skin tightening, ILD, PAH, everything.
Okay, sir.
Right?
Okay, sir.
Hmm. Right. Yeah.
Yes, sir.
Is there anything else you want to discuss?
Sir, yes, sir. So this was a panel, sir. Scleroderma panel, and it showed SCL70 was strongly positive, sir.
Mm-hmm.
And centromere was negative, sir. Then fibrillin was negative. PMSCL was negative, sir. Anti-Q, then PDGFR was negative, sir. Rho 52
Yeah,
was
we
also
can
negative,
see.
sir.
Like, so what is your inference?
So, yes, sir.
Yeah, so what is your
Sir,
inference?
as we can see,
Patient is strongly
sir,
positive for
one thing there is
SCL70.
any, Yes, sir. So this says that the patient ILD can be attributed to this disease, sir.
Okay. Okay.
And since it's strongly positive with the progression is very fast, and it also helps us in treatment course. And since RNP3 is negative, then screening for carcinomas like breast carcinoma.
No. You don't call it RNP3. It's RNA polymerase 3.
Yes, sir. RNA polymerase 3.
So
yes,
where is RNA polymerase 3 here?
sir. Okay, sir.
You don't find it here.
No, sir. RP.
Yeah. So RP11 and RP155 are the two epitopes of RNA polymerase 3 which are tested. Okay. So generally, when patients are RNA polymerase 3 positive, they'll be positive for both RP11 and RP155.
Okay, sir.
Okay. So basically this 11 and so when you find these numbers 70, 11, 155, these are all the size of the what do you call the epitopes. 70 kilodalton, 11 kilodalton, 155 kilodalton. So when you have these immunoblots, this immunoblots will have the antigen. Your serum possibly has the antibody, and the antigens are identified by one of the important things which helps you identify the antigen is their weight. So this 11 kilodalton, 155 kilodalton helps you identify what particular antibody the patient has. So the RP11 and 150 are the RNA polymerase 3 epitopes.
Okay, sir.
Okay.
Okay.
Okay, so let me ask you certain basic questions before we go into discussing the treatment. So you said to differentiate between primary and secondary Raynaud's, lack of systemic features suggests more of primary Raynaud's. A young female, more of primary Raynaud's. Nail fold capillaroscopy, you said if it is abnormal, it is mostly secondary Raynaud's.
Yes,
and if ANA is positive, the patient has secondary Raynaud's. What else? Just based on the Raynaud's, does it? Is there anything which helps you differentiate between primary and secondary?
Sir, the complaints will be short and brief, sir. The pertaining to that Raynaud's.
Okay, the severity of the Raynaud's will be mild and primary.
Yes, sir.
Okay. What else?
Then there won't be any ulcerations. If there is any development of ulcerations, then we have to suspect.
Fine. Okay. So I'll give you a scenario. Suppose you have a 20-year-old girl who has Raynaud's in the index finger and ring finger of her left hand and thumb and little finger of her right hand. What does it suggest? Is it primary or secondary?
In the left it is
index and ring finger, right it's thumb and little finger.
Sir, it could not be, it can be secondary, sir.
Why?
It should involve should have been an uniform involvement.
So it is the asymmetry. So when you have asymmetric Raynaud's, then it is likely to be secondary Raynaud's. What else? If you have Raynaud's in all 10 fingers, what does it suggest?
Then it can be primary.
So symmetry most likely suggests that it could be both. It could be both primary and secondary. But what they say is that if you have involvement of the thumb, it is mostly secondary. Okay.
Okay, sir. Okay.
Yes. That's about the primary and secondary because you need to know that. You need to identify in terms of the character of the Raynaud's, the severity of the Raynaud's, association with ulcers and skin ulcers and scars, association with nail fold capillaroscopy, association with systemic findings and ANA.
Okay, sir.
So suppose this patient has difficulty in eating, this patient has loss of weight. Okay. What are the factors that can cause difficulty in eating in this case?
Sir, one is dysmotility, sir. The other one is the patient can have a GAVE, sir.
GAVE? Do you think GAVE will cause difficulty in eating? Most of the patients of systemic won't even know that they have GAVE.
Okay, sir.
You can find it in asymptomatic people also.
Okay, sir.
Where GAVE is gastric antral vascular ectasia for the purpose of the audience. Most of the time it's an incidental finding. Or if you suspect that the patient is having any bleeding, is anemic and you don't find a reason for that, That is
Okay,
when
sir.
you think of GAVE. What are the
Okay,
other
sir.
factors which contribute to difficulty in eating?
Sir, one thing, because of skin thickenings, she couldn't able to eat, hold, not able to use spoons, and due to reflexes,
Okay.
probably, sir.
Okay. So, don't you think she has difficulty in opening her mouth? Her mouth opening
Yes,
is
sir.
limited.
Yes, sir. Yes, sir. Her, it's not, the mouth opening is not adequate, sir.
Hmm.
It's less than two fingers, sir.
Okay.
Yes, sir.
Yeah. So think of other factors like this.
Yes, sir.
What else can
She
cause
had
difficulty
dental
in eating?
caries also, sir. Yes, sir.
Okay, caries. So what does caries cause?
She's not able to chew properly.
Okay, very good. What else? What else does this patient have which can increase her difficulty in eating, difficulty in swallowing?
Sir, she had dryness of mouth also, sir. So
Okay, very good.
salivation. Then there can be any strictures. We don't know, sir. We should have
Strictures
seen
where?
the
Esophagus. Because of what?
Because
I
of
think this patient has got a systemic sclerosis, increased risk of strictures.
not so sure, sir.
Okay, mostly it does not directly cause, but sometimes the patient
Okay,
can
sir.
have associated iron deficiency anemia. It can cause
Okay, sir.
esophageal web or something like that.
Okay, sir. Okay, sir.
Okay.
Yes, sir. Yes, sir.
What else? You said about the mouth opening teeth. These patients can have bad oral ulcers.
Yes, sir.
Okay, so oral ulcers can impair their eating. One more important thing is because of the dry mouth,
Yes,
they
sir.
are at increased risk of candida,
Okay, sir. Okay,
oral
sir.
thrush. So candida
Okay, sir.
can cause difficulty in swallowing,
Okay, sir.
can alter the taste.
Okay, sir.
Okay, so they won't feel like eating. So the
Okay,
taste
sir.
change, presence of candida and GERD. GERD can cause
Okay, sir.
pharyngeal ulcers, pharyngitis. It can cause odynophagia. So
Okay,
there
sir.
are so many factors which can cause difficulty in swallowing. There's one more factor, which is
Yes, sir.
concomitant myositis. Suppose the patient has got concomitant myositis, then it can cause difficulty in swallowing. Then there are very rare factors like they can have achalasia cardia,
Okay,
or it
sir.
could be an esophageal malignancy also.
Okay, sir.
Okay, so there are so many things when somebody with scleroderma says they cannot swallow food or they
Yes,
are
sir.
not able to eat well. There are so many things,
Yes, sir.
and obviously the things like dysmotility. They could have
Yes, sir.
very bad GERD. They could have gastroparesis. There are so many other
Yes, sir.
factors which can impair their ability to eat. Suppose
Yes,
this
sir.
patient has diarrhea. What does it signify?
Sir, the patient can have small bowel intestinal overgrowth, sir, bacterial overgrowth.
Okay. What else?
Then the patient can have any obstructions at the pneumointestinalis. They can have distension.
Any obstruction? Do you think obstruction will cause diarrhea?
Sir, small absorptions.
Okay.
Not so sure, sir.
So yeah, like you said, small intestinal bacterial overgrowth can cause diarrhea. These patients are at increased risk of infections.
Okay, sir.
You're going to give them immunosuppression, they are at increased risk of diarrhea. They have this dysmotility, so they can have this alternate periods of having diarrhea and constipation. And a lot of patients with systemic sclerosis have fecal incontinence. So that can be misconstrued as having diarrhea.
Okay, sir.
Okay.
Okay, sir.
What else should I want to ask you?
Move the slide.
Okay, so let's come to the treatment part. Like you have investigated the patient. This patient has got a diffuse cutaneous skin tightening with ILD, with SL70 antibody.
Yes, sir.
And you want to treat the patient. What are your options?
Sir, the first thing is, since the patient has rapid progression, you should give her higher immunosuppression.
What is your idea of higher immunosuppression?
Sir, induction with rituximab.
Okay.
Then
is rituximab an approved drug for systemic sclerosis? FDA approved drug for systemic sclerosis?
No.
Okay, it is not, but it is recommended by all the guidelines. So rituximab is one option. What else? What is the most commonly used drug in the world for systemic sclerosis ILD?
Sir, can use
Sorry.
Ninactinib.
No. See, this patient has a very recent history. This patient has got rapidly progressive skin tightening with ILD. Everything has happened
Okay.
rapidly. So your idea
MMF.
of it, see, the thing is, there are two things in ILD. One is inflammation and the other one is fibrosis. And something
Okay, sir.
happens so rapidly, you think it's more of inflammation. So do you
Okay,
think
sir.
Nintedanib is the first option? Like, I
We
guess that's
can
what you wanted to
go with
say.
MMF for
Okay.
cyclophosphamide.
Cyclophosphamide. Okay. So what will be your first option? 1, 2, 3. Rituximab,
Sir, mine will
cyclophosphamide,
be MMF,
MMF,
sir. First one will
Nintedanib.
be MMF, sir.
Okay.
Followed by cyclophosphamide, sir.
Okay. Why cyclophosphamide?
Sir,
See, the problem with cyclophosphamide in systemic sclerosis, the difficulty is
yes, sir.
like what has been seen from trials is the increased risk of infection.
Okay, sir.
Compared to you take mycophenolate mofetil and rituximab, there's a slightly increased risk of infection. Obviously, in the Indian context, cyclophosphamide is a cheap drug, so you can offer it to your patients. So
Okay,
yeah,
sir.
you can consider either of those three. But
Okay, sir.
worldwide, if you see, rituximab and MMF and rituximab are the two commonly used options. Cyclophosphamide is sort of being phased out for systemic sclerosis ILD. But in
Okay, sir.
resource limited settings, and your patient is not, the patient has financial constraints, you can still consider cyclophosphamide.
Okay, sir.
Okay.
Sir,
So,
is there an option for any Plex or IVIG, sir?
no, definitely not. Plex,
Will
it's
it be
because it's a
useful, sir?
very slow chronic condition, Plex has no role. IVIG also does not have any role.
Okay, sir.
Okay. So
Okay, sir.
IVIG and only if, there's something very urgent and you need to correct that. Like say, suppose the patient has a say platelet count of 2000 and you want to correct that.
Okay, sir.
Okay. Or say this patient has, uh, you know, like not specifically in this case, but
Okay, sir.
this patient, like say you take a patient of lupus, when do you want to give IVIG?
Sir, when the patient has diffuse
When you
cellular
need very rapid improvement. Suppose
yes,
the
sir.
patient has got macrophage activation syndrome, or
Okay, sir.
say when the patient has got a very bad disease activity with infection. So
Okay, sir.
those are the situations in which you want to use IVIG. Systemic sclerosis, you hardly will ever want to use IVIG. What
Okay,
other
sir.
drug? Like, see, suppose you have this patient has like a say CRP of 3 milligram per deciliter, rapidly
Okay, sir.
progressive skin tightening with ILD. What other options can you use? The drug is available in India. It is FDA approved for systemic sclerosis.
Not so sure, sir.
Okay, so you can use tocilizumab also. So
Okay, sir.
tocilizumab has, from the medications used for ILD, it has shown the maximum benefit of FVC. So
Okay, sir.
tocilizumab is another option you can use apart from
Okay, sir.
whatever you said, rituximab, MMF.
Okay, sir.
Can you use methotrexate in this case?
Sir,
Okay, so methotrexate is not an option you would find because you don't want to give methotrexate in a patient with already a lung condition
okay, sir.
because it has the a potential for worsening of ILD. But
Okay, sir.
methotrexate, it is an option, but see the effect size, the like you calculate skin tightening in terms of modified Rodnan skin score.
Yes,
The
sir.
amount of reduction in skin score you can achieve with rituximab is much higher than what you can achieve with methotrexate. So, in such a
Okay, sir.
patient where you want to treat for ILD as well as skin, you prefer something like rituximab or MMF, which can have
Okay,
an
sir.
effect on the skin and lung rather than use just methotrexate because it will have some effect on the skin. Okay.
Okay, sir.
You can use tocilizumab. Tocilizumab is also an option.
Okay, sir.
Suppose you have exhausted all options. The patient has progressive skin tightening, has very bad contractures, has myocardial disease, has very bad lung disease, and you have used all these options. The patient is still progressing. What else can you offer the patient?
If the lung become very bad, we can, if all medical options are cleaned off, we can go for
Surgical option.
transplant.
What will you transplant?
Lung
No,
transplant.
no. There's something else you can transplant which can make the patient better.
Autologous stem cell.
Yeah. So autologous stem cell transplantation, if you can cross the initial period of morbidity, has some of the best results in systemic sclerosis.
Okay.
It is another matter that, it is not done very widely, but some of the best results of systemic sclerosis has been achieved with autologous stem cell transplant. Okay.
Okay.
What else? What other newer treatment still not available can be offered for patients with systemic sclerosis?
Sir, I'm not so sure.
Okay.
Yeah.
Okay. So probably in future, CAR T cells might also be used.
Okay, sir.
Okay.
Okay.
Okay. So apart from treating ILD and skin tightening, what else do you want to treat in this case? Like, what will your prescription for this patient include?
Sir, the thing is, even though this patient didn't have any ulcerations, sir, we have to give a low dose uh, phosphodiesterase inhibitors, sir.
Right?
Second, sir, these patients invariably will have vasculopathy, sir.
Okay.
So,
Okay. So you are predicting that this patient will have vasculopathy and treating. Okay, fine. What other advantage will like a phosphodiesterase 5 inhibitor will have in this case?
sir, prevent progression of pulmonary hypertension.
Okay.
And,
See, potentially PDE5
Yes, sir.
inhibitors have some role in slowing the progression of ILD also.
Okay,
They
sir.
have some antifibrotic role also.
Okay, sir.
So, and like you said, it reduces the worsening. Yeah. So you will give PDE5 inhibitors. What else will you give?
Sir, we can give low dose ACE inhibitors, sir.
Why? Why? What added advantage will it give? Like, do you think ACE inhibitors have a role in preventing systemic scleroderma crisis?
No, sir. I'm not so sure.
Okay, it does not have any role in preventing.
Okay. Okay, sir.
What is one drug like ACE inhibitors which you can give in this case? Something like this. You can use ARBs. So
Okay.
ARBs
Okay, sir.
have a role in vasculopathy. You can use them.
Okay, sir.
A lot of cases you can use ARBs.
Okay, sir.
Okay,
Okay,
so
sir.
apart from the immunosuppression, either MMF or rituximab or cyclophosphamide, you will want to like address the vasculopathy in this patient. So you
Yes,
use
sir.
either PDE5 inhibitors or why don't you use CCBs, calcium channel
Sir,
blockers?
sir, nifedipine can be used, sir.
Okay. Why don't you want to use in this case?
Sir, since the patient doesn't have any Raynaud's.
No, the patient does not have any pain. So why do you want to use
Yes, sir.
PDE5 inhibitors in the first place?
Yes, sir. The CCB is mainly used for Raynaud's and ulcers, sir.
Yeah, PDE5 inhibitors also used for that.
Yes, sir.
Yeah, so you don't want to worsen the GA manifestations in this case. Like
Okay,
if you
sir.
use diffidipine, they can worsen your GA manifestation. And in
Okay,
somebody
sir.
with bad GERD, I generally tend to prefer PDE5 inhibitors over this thing.
Okay, sir.
Okay. Suppose this
Okay, sir.
patient, what else? What else will your prescription have?
Sir, PPAs.
Okay, PPA, okay.
Then
PPA only, or do you want to use any prokinetic?
sir, with prokinetics.
Okay. So what are the possible prokinetics you can use?
Sir, we can go with domperidone, sir.
Okay.
Then
Okay. Are you aware of any other prokinetic which can be used in this case?
Sir, metoclopramide.
No. Something which will have a better GI effect.
Sir,
Metoclopramide, do you use very routinely for this thing?
sir,
Okay,
any,
go read. So basically, you use 5-HT4 agonist,
okay, sir.
etopride, prucalopride,
Okay, sir.
mosapride, those things. Okay.
Okay, sir.
Those are the things you can use.
Okay, sir.
What else? What else will your prescription have? Will you give this patient steroids?
Sir, yes, sir. Since the patient has myalgia,
You give steroids for myalgia. See, this patient has some
arthritis.
joints, right?
Yes, sir. Arthritis.
Yeah. So you can give some steroids. You can maybe give prednisone
Okay, sir.
5 milligram for shortest period possible, so that they get relief from. Like suppose you give mycophenolate mofetil. Mycophenolate mofetil does not have any significant effect on the joints. So if you're
Okay, sir.
preferring mycophenolate mofetil, you need to give the patient something for the joints,
Okay, sir.
and probably you can use. So we're discussing about systemic scleroderma renal crisis. Do you think SCL70 causes risk of scleroderma renal crisis?
Sir, the greater risk is with U1 and RNA polymerase.
No. U1 RNP does not have any risk of scleroderma renal crisis. It's only
Okay,
RNA
sir.
polymerase 3 which increases the risk of
Okay, sir.
scleroderma renal crisis.
Okay, sir.
Number one is RNA polymerase 3. Number two is SCL70 only. The
Okay,
other
sir.
things, they are U1 RNP can cause renal disease in different ways, but
Okay, sir.
not scleroderma renal crisis.
Okay, sir. Okay, sir.
U1 RNP, see, you don't
Okay.
confuse anything with RNA polymerase 3 is different, U1 RNP is
Okay, sir.
different, U3 RNP is different. Even though these
Okay, sir.
names sound similar, they are all very different.
Okay,
RNA
sir.
polymerase 1 is different. So,
Okay, sir.
okay.
Yes, sir.
Yeah. Yeah, so as one of the most important things you need to do in such a case, one of the reasons why this patient got this extended panel for systemic sclerosis, because usually in your ANA blots, you'll only have
Yes, sir.
SCL70 and centromere.
Okay, sir.
Suppose if you do an ANA blot and this patient comes out to be SCL70 negative, then what will you
Okay,
do?
sir.
Then you'll have to get this whole thing to see what sort
Okay,
of
sir.
antibody the patient gets. So it is better
Okay, sir.
to get this thing upfront,
Yes, sir.
because a lot of the prognosis for these diseases is decided by the antibody which is present in them. Whether
Okay,
they
sir.
are at increased risk of malignancy, increased risk of scleroderma renal crisis, increased risk of pulmonary hypertension,
Okay, sir.
increased risk of myopathy, all those things. So you can
Okay,
get
sir.
a wealth of experience from, wealth of knowledge from the
Yes,
antibody profile.
panel. Okay.
Yeah.
Yes, sir.
And obviously, see, diagnosing a patient with systemic sclerosis is just a starting point.
Okay, sir. Okay, sir.
The patient is going to trust you for a lot of treatment decisions. The treatment is going to go on for years.
Okay, sir.
There'll be ups and downs. So you need a lot of patience. Systemic sclerosis is something which will not improve within a few days. Sometimes it will take months and years. Sometimes the
Okay,
patient,
sir.
you need a very patient patient to stick with you. You also need
Okay,
to be
sir.
patient, not jump the gun in changing treatments. Like suppose you
Okay,
don't
sir.
find any improvement in 1 month, you should not like just change it to,
Escalate.
like say, change
Okay,
MMF
sir.
to something else.
Okay, sir.
Yeah, systemic sclerosis is not such a simple disease.
So usually these patients will have a poor prognosis, sir, invariably, or they will
Uh,
do well, sir.
so see, it depends what you call as poor prognosis. So
Okay, sir.
poor prognosis is dictated by time. This patient you have picked up sort of early. If you start treatment early, and if the patient has a stable FVC, like say if you follow the patient for 5 years and if they have a relatively stable FVC, then it is sort of unlikely that they will progress. And so in such a patient, what you're worried about is progression of ILD
Okay,
and
sir.
infection.
Malignancy.
So you need to balance those things.
Okay, sir.
and the patient should be fine.
Okay, sir.
And there are a lot of other factors like GI disturbances, a big problem for these patients. You need
Okay,
to
sir.
sometimes even keep changing the drugs. There are
Okay, sir.
gastroenterologists cycle the drugs. Like say they'll give domperidone for 2 weeks, etopride for two
Okay, sir.
weeks, something else for 2 weeks. They keep cycling.
Okay,
Sometimes
sir.
they need cyclical antibiotics to prevent
Okay, sir.
bacterial overgrowth. Okay,
Okay, sir.
so there are a lot of complications which can happen in these cases. Sometimes when they can have complications like pseudo obstruction, which need like they have to be NPO, be put on something like an octreotide.
Okay, sir.
In such a situation, you can also try IVF.
Okay, sir.
So
Okay, sir.
patient might be like this now. In one more year, it could be something else. So it's a constantly evolving thing where
Okay, sir.
something else might crop up.
Okay, sir. Sir, anything else will be there, sir? Like other than these things, any other drugs that can be tried, sir, that can improve?
Right now, these are the only drugs we have. For ILD, we have mycophenolate
Okay, sir.
mofetil, rituximab, tocilizumab, and nintedanib. Nintedanib can be used as an add-on.
Okay, sir.
Is see, there are trials in which you can use nintedanib, but the improvement in FEC is very minimal, and most of the improvement in FEC you can get when you use a
Okay, sir.
combination of mycophenolate mofetil plus nintedanib, or a combination of rituximab plus nintedanib.
Okay, sir.
So it's never that nintedanib is started.
Okay,
Like,
sir.
if you look at any of the guidelines,
Okay, sir.
none of them suggest that you start
Okay, sir.
nintedanib and then add on other drugs. So nintedanib is one. So the aim is to researchers have been looking at TGF inhibitors. None of them have
Okay,
been
sir.
successful so far. Something which inhibits transforming growth factor, which is a very strong pro-fibrotic factor.
Yes, sir.
None of them have been successful in trials so far. But probably in future, some molecule might come which could be effective in blocking TGF beta. There are some other molecules, cannabinoids. There is a molecule called lenabasum which has shown some benefit in trials. Maybe it can be used as an add-on therapy for in addition to mycophenolate mofetil, something like that.
Okay,
So
sir.
it's an exciting field where new drugs are constantly coming. So if you
Okay,
look
sir.
at the last 5 years in systemic sclerosis ILD, two new drugs have been approved. One is tocilizumab and the other one is nintedanib. So
Okay, sir.
initially, this condition was thought that you can only use cyclophosphamide and nothing else was there until 2010.
Okay, sir.
And after that, you have been able to use rituximab. There are lots of studies which have shown good results. And then you have mycophenolate mofetil. You got
Okay,
nintedanib. So you never know what the next 10 years is going to bring. It's
okay,
quite
sir.
a long time in medicine.
Okay, sir. Is there any drugs to be avoided, sir, which can worsen scleroderma? Nothing like that, sir.
Drugs to be avoided. Obviously, you don't want to give too much steroids because steroids are more a harm than good. You
Okay,
don't
sir.
want to give the patient methotrexate or things like that.
Okay, sir.
Okay. You don't want to use
Okay, sir.
unnecessary drugs also. You don't want to use ACE inhibitors
Okay, sir.
and generally you avoid beta blockers
Okay, sir.
because they can cause unchecked alpha inhibition.
Okay, sir.
It can worsen Raynaud's.
Okay, sir.
Yeah.
Okay.
So these are the things.
Yes, sir. Will be,
Yeah, I think we have had a good enough discussion.
yes, sir.
Hopefully you got to learn a bit,
Yes, sir.
as does the audience.
Yes,
I
sir.
think if it's
This patient was
okay
treated
with
with rituximab, sir, 2 doses.
yeah.
Yes, sir. And the score became 22, sir, from 26.
Okay, so that it's too early to say. So
Yes,
this
sir.
patient has only been with us for a month, so it is too early to say whether it is a significant improvement. So see,
Okay, sir.
before you say a significant improvement, you need to know that what is a clinically meaningful benefit. Okay,
Okay, sir.
so you cannot call a reduction of 4 MRSs as a clinically meaningful benefit. For all you know, the patient
Okay,
does
sir.
not feel anything different, and 1 month is too early to even feel any difference.
Okay, sir.
Okay, so you can maybe assess the patient after 3 months or 6 months. That is when
Yes, sir.
you'll really know whether the patient feels any improvement.
Yes, sir.
See, with scleroderma, it's a waiting game.
Okay, sir.
The patient has to be patient. You have to be patient.
Okay, sir. Yes, sir. We'll
I think
close the.
if the organizers are okay with it, we can
Yeah,
close.
yeah. Dr. Sundaram is in-depth discussion on the antibody assay and interpretation of the individual factors in relation to clinical correlation. So it's nice discussion on this aspect, and you've gone in depth. Probably, definitely, the postgraduates who are following is able to follow at least 50% of your discussion. They're more benefited than definitely, no doubt about it. And I think Kalai also presented nicely. I think he was able to cope up with your questions to some extent, and he was able to answer also. Hopefully, you might have prepared well. Really,
Yes,
thank you,
sir.
Dr. Sundaram, for a wonderful discussion on this topic of rheumatological aspects. Even there's a single case, but you're able to cover up the important aspects of therapeutics as well as investigations on this topic of the common problem, what they're coming across as a clinical problem. And appreciate Kalai for presentation also. Anything else you want to say, can say, otherwise we'll call it a day, Dr. Sundaram.
Yeah. Thanks a lot, sir. Thanks a lot for
Thank
giving
you.
me this opportunity.
Yeah.
I want to congratulate Kalaivasan for taking the effort to make this presentation and making a good job. So it's not easy as a postgraduate resident to present a rheumatology case because it's something you don't commonly see. So I appreciate the effort you've taken.
Thank you, sir.
Thanks to Dr. Saravanan for giving me the opportunity once again.
Yeah. Thank you, and good night to all of you. Thank you.
Yes.
Thanks,
Thank you,
sir.
sir.
Good night.
Yeah.
Thank you.
Yeah.